All right, we will go ahead and get started. Welcome, everyone. My name is Cindy Manginelli, and I'm the Director of Community Engagement with the National Healthcare for the Homeless Council. If you're not familiar with the Council, we are a national training and technical assistance program funded by primarily by the federal government, although we have other funding streams today, like the one that has funded this program that you're enjoying today. I would invite you to go to our website, nhchc.org, and you will find tons of resources in all things at the intersection of healthcare and homelessness, and also a lot of resources around mobile health. I know many of you are joining us today because of your relationship with the Mobile Healthcare Association, and we are really thankful for our friends there at MHA. I would encourage you to visit their website as well, and they have an abundance of resources specific to mobile health. We have been doing September and October learning sessions based around mobile health, and they have been funded by the Leon Lowenstein Foundation, and so we are very grateful for our funders at the Lowenstein Foundation. We had 2 sessions that we did in September on safety and security in mobile health, and then we're doing 2 sessions in October. This is our 2nd session on funding your mobile unit and different ideas about financially sustaining your unit. So if you're registered for the session today, which you are, if you're sitting here, then we will send you the recordings for these, and you will also receive the link to join us for our October and November Lunch and Learn on the Go series, which is a Lunch and Learn series on mobile health. Each week, beginning a week from today at this time, we're going to feature one mobile unit, and they're going to explain to us how they're funded, why they started, their outreach policies. Basically, they're going to give us a complete overview of their unit and what they do and why they do it. And each week we will feature a different unit in a different part of the country, lots of unique aspects to each of the units that we're featuring. So I would invite you to join us for that. You will receive the link to that with the recording to this session. And with that, we have 2 parts to our session today, both I think that are going to be really valuable. The first part, we're going to feature with our friends from NAC, and I'm going to let Nova introduce herself here in just a minute. We're going to talk about some exciting things in the world of policy around mobile health. And then we will introduce you to Molly, and she will introduce herself, and she's going to explain to us some truly amazing work that's been nationally featured on building a business case for mobile health. So we're going to go ahead and get started. I'm going to turn it over to Nova from NAC to introduce herself and to talk about the world of policy as it relates to mobile health.
Thank you so much, Cindy. Hi, everyone. I'm Nova Thayer. I'm a program associate. I work at NAC on the federal affairs team. So passing bills, policy, it's pretty much my main forte. So we at NAC, just a brief overview, we represent community health centers in Congress, and we make sure that they're getting the necessary funding they need to take care of all the people in the community. And mobile health is an important part of that. So we tend to get involved in legislation related to that. So today we're covering 2 kind of provisions and bills that passed in the last couple days. The main one is the Mobile Healthcare Act, or Senate Bill 958. To briefly summarize what the bill does, it basically changes the 330 grantee program to, for some context, previously when you wanted to get a new mobile unit using new access point grants through community health centers, you basically also had to make a full brick and mortar permanent site at the same time in order to get funding for it, which when it comes to mobile units, that's not really that practical, because especially for more rural areas or even in more urban centers, you really need just a mobile unit, right? So this law expands and modifies the program. So you can basically apply for a mobile unit through the new Access Point Grant program without also having to build a new building at the same time. So as an aside, we expect this to expand primary care services in rural areas significantly on the condition that the new Access Point program gets more funding. A little more context on the bill. It was originally kind of created by Senator Rosen, Senator Collins, and they read the Senate version, and then the House version is Representative Lee, Representative Rees, Herrera Butler, and Representative Hudson. They all did the House version. And the interesting thing about that bill, it was just very bipartisan, just kind of hard to get on the tracker with so much going on. So we at NAC worked to make sure that it was a high priority for leadership. And thankfully, it passed in the Senate September 6th. So we're very happy about that. And then it passed on the House on September 29th, right before everyone in Congress went out for the election season. Overwhelmingly bipartisan, which is rare in today's day and age. So that was nice, like 414 to 7 in the House. And I'm happy to report that this slide's a little out of date. It got signed into law October 17th. So we are very happy that it got signed into law. And we really think that this will help when new access points gets more funding. So we don't have much to say on that right now, but we're gearing up for our mandatory funding ask. So more to come on that. Yeah, it's a brief overview of the Mobile Healthcare Act. Please put in the chat if you have any questions. I'll try and answer them. And then here's another bill that's also somewhat related to mobile health. So it's expanding FTC coverage for health center volunteers. Basically, there's been a successful program in place for the last couple years that allowed health centers to have volunteers to come into their health center, say, I want to volunteer, typically during a disaster event or some horrible storm, some major event going on. You really need volunteers to help with the surge of people. So this is what this bill basically allowed. Unfortunately, it was set to expire originally on October 1st, 2022. So we at NAC kind of have been pushing for the last couple months, but basically around September to get the language for the continuing, basically get the language of the bill included in the continuing resolution, which was the temporary package that passed on September 30th, which continued to fund the government. So we got a permanent extension of this law for volunteer health professionals. And the reason that's important is if this law expired, all these health professionals do undergo a certification process so they can help in the local communities. Need to make sure you're qualified. It is a somewhat lengthy process. So if it expired, everyone would have to go through that again. So the hundreds of volunteers that currently use this program would not be able to use it. So we're very happy that it got extended when it did, because again, it's a highly bipartisan thing. We had significant support from both members, both House, like the House and the Senate, the committee heads. Everyone was in favor of it. It was just the question of putting it into a specific bill or not. So we're happy to report that effective immediately, the program will continue and you can still rely on volunteers for any extreme events that occur, such as environment, weather, that sort of thing. And this is to just give an overview of how policy affects kind of the mobile health environment in general. A lot of this stuff can lead to expansions. It just requires a bit of tweaking here or there. And we at NAC believe this is a very bipartisan issue. So it just requires a bit of pushing in some areas, but can definitely lead to major improvements in the field and how it works. So yeah, that's just kind of a brief overview of the legislation. And please put any questions in the chat. I'll be happy to answer them. Back to you, Cindy.
Awesome. Thank you so much, Nova. That's exciting. That's exciting to think about. All right, I am going to, I think there were some questions in the chat, but I think they were addressed. So I know you'll kind of keep an eye on that too. And now I'm going to turn it over to Molly to introduce herself and to talk to us about making a business case.
Sure. Thanks, Cindy. Just give me a second here. I'm going to share my screen. Great. Can you see my my first slide? Awesome. Thanks, Cindy. So as you heard, my name is Molly Williams. I'm the Executive Director of Mobile Health Map, a program of Harvard Medical School. I also lead a local mobile clinic here in Boston called the Family Van. It's a mobile clinic run by community health workers. We've been in the community for more than 30 years. And the work that I'm going to talk about through Mobile Health Map was really inspired by our experiences here in Boston. I'm also on faculty at Harvard Medical School in the Department of Global Health and Social Medicine. I provide my contact information at the end of this presentation, and I do encourage you to reach out if you have any questions. Mobile Health Map is a network of mobile clinics working together to advance health equity. We work together to innovate, evaluate, and communicate the impact of mobile clinics. More than 1,000 mobile clinics have registered on Mobile Health Map, and together we're working to increase access to healthcare and achieve equity. Even though we only have 1,000 folks on our map right now, we estimate there are more than 2,000 mobile clinics in the US, and together we serve about 7 million patients each year. We published a study, Dr. Nancy Oriel, the founder of Mobile Health Map, published a study in 2009 that examined the costs and savings associated with the family van, the mobile clinic here in Boston. And through that study demonstrated a return on investment of 30 to 1. For every dollar we spent on the family van, we were saving $30. And I'll talk more about that later. That then inspired the creation of Mobile Health Map as a way to share that assessment and the tools that we use to do that assessment on our van, to share that with other clinics around the country. And so we began Mobile Health Map shortly after that paper was published in 2009 in close collaboration with the Mobile Healthcare Association. We also recently issued a report, The Case for Mobile, which describes how mobile healthcare supports the business objectives of healthcare organizations in other ways. They support new business development. They help organizations to build trust and credibility and improve organizational culture. These benefits are harder to quantify, especially at the national level, but they're just as important. Also, to clarify on this slide, you see the 12 to 1 return. As I mentioned, the Dr. Oriel's paper calculated at 30 to 1. That was just for one mobile clinic. And as we collected more data, which is what we do in Mobile Health Map, clinics from around the country enter in their data, we now have a better estimate with more participants, and that's the current average is 12 to 1 for return on investment. Still a very powerful statement about the potential of mobile clinics to save lives and save money. As many of you know, mobile clinics serve diverse populations around the country. Every mobile clinic is different. So for example, the family van, our mobile clinic here in Boston, about 90% of our clients identify as people of color. The mix of people served and the communities that are served really vary across the country. But as you can see, most mobile clinics are reaching a diverse set of community members. They're also reaching marginalized communities. We ask them in Mobile Health Map to tell us what are their primary populations served. And this is just some of the data. So as you might expect, you see many clinics that are focused on serving the uninsured and low income individuals, as well as people experiencing homelessness, rural communities, veterans, public housing residents, and LGBTQ populations. And then mobile clinics are delivering high value care. So this slide may be a little difficult to see, but you'll see here that the majority of care falls into the categories of preventive or primary care. A big portion is dental. And then also we've got pediatrics, behavioral health, mammography, asthma, and maternal infant child health. So that was a quick overview of the sector, and many of you know about mobile clinics already. So let me tell you what I'm going to focus on today. I really have 3 main points. So if you don't hear anything else, this is what I'm going to say. First, health equity is a moral and an economic imperative. So I'm going to talk some about the economics of health equity and specifically of mobile health care. I'm also going to talk about the ways in which mobile health care aligns with different types of organizational goals. And by organization, That could be any player in the healthcare marketplace. So that includes hospitals, payers, community health centers, universities, large hospital systems. There are lots of different players, as you guys know, in healthcare, and there are ways to look at their organizational objectives and align them or align mobile healthcare objectives with their goals. And that can help in sustaining your program, gaining support and sustaining a mobile health program. And then finally, I'm going to talk about how you can use those business related arguments to gain support to start or expand your program. So I believe I can now see the chat, and I'd love to just ask you to drop in the chat your answer to this question. What keeps you awake at night? Now, it could be the neighborhood dog or the loud music upstairs. But if there's something work related, I'd love to hear that too, because that's going to help me make sure I'm addressing those concerns as best I can as I continue the presentation. So just take a minute to share in the chat what keeps you up at night. Funding, I see one. Thank you, Elizabeth. Funding, budget, Melissa, thank you so much. Keep them coming. We have a trend. Now we certainly have a trend. We've got 3: securing funding for adequate staffing. What else? What else keeps you up at night? Growing community needs. Yes, definitely. Funding for the staff. Oh, and the van breaking down. That is a real challenge because our communities depend on us to be consistent. And when it breaks down, that consistency is hard. Planning for sustainability. So another vote for funding and all the things that are required for sustainability. I want to see Donica, you say this is important. Complete and devastating, lacking safety net system in Texas. No Medicaid expansion here. And that really affects our work with homelessness, housing, healthcare access. Yes, I hear that. Lack of providers, qualified staffing. Okay, so I'm hearing the trends, the same trends that we see with mobile clinics around the country. Funding, sustainability, staffing, retention and burnout, and then the systems in which we work, for example, a state where there is no Medicaid expansion, and also working in systems where there's no or not enough options for affordable housing and healthcare access. So thank you for sharing those. That's really helpful. And as I go through, I'm going to talk about funding, and to some degree, I'll also talk about human resources and how mobile clinics connect to organizations' human resources needs. Now, one more question. Again, if you can drop in the chat, what are your organization's most significant challenges? And when I say organization, that could be like your unit, if you have a mobile clinic, your mobile clinic could be your clinic in a bricks and mortar clinic, or it could be even the larger organization. So if you're part of a hospital system or a county or a large federally qualified community health center or lookalike, what is that organization thinking about? You could also think of it as if the CEO and the CFO and the COO, all those C people got together and shared what they're really worried about, what's keeping them up at night, what do you think they would say? So just drop that in the chat. I'm interested to see if it's the same or maybe it's different than what we saw and what's keeping you up at night. Great, here we go. Sustained funding and employee burnout. Yes, yes, yes. Missouri's decentralized and fragmented public health system. Yeah, we could probably replace the word Missouri there with just about every state in this country. Our public health system is, as we all know, in a crisis and has been in crisis mode. Money, yes, funding and staffing. And then here specific to mobile, logistics, not having a set amount of staff just for mobile, pulling staff from our bricks and mortar, overarching, yes, staff turnover. And yes, Venus, thank you for introducing yourself. Retention and more rigorous training of various staff roles, cost, continue to rise, and reimbursement is stagnant. Oh, yes, I hear that too. We'll keep it coming. I'm going to move on, but please do share these. I think it's helpful for everyone to hear what we're struggling with. And I'll do my best to speak to these issues I see continuing to come up, especially financial resources and human resources, as well as the larger or how those connect to larger system issues, whether it's the public health system or the state Medicaid system. Yes, so let's keep going. Thank you. So I started out by saying that health equity, and this isn't just specific to mobile health care, but health equity is both a moral imperative and an economic imperative. And so I suspect I'm speaking to the choir here when I talk about the morality of advancing health equity. So let me just spend a minute on that point. I have two quotes here. This first one is from Don Berwick, former head of Institute for Healthcare Improvement and then CMS. He wrote a really important article, I think it was in 2020, called The Moral Determinants of Health. And he wrote, the moral force of professional leadership, speaking of healthcare leadership, can also be powerful once grounded and mobilized. A difficult question follows. Ought the health professions and their institutions take on this redirection? To use a recent vernacular, what's in healthcare's lane? So there's a moral force that we have as healthcare professionals and as leaders of organization. And how should we mobilize that force to ensure that people get the care that they need? And I would argue that most of us in this virtual room right now are already mobilized and are strongly motivated by our beliefs, our morals about, I'll just speak for myself, that I believe that everyone deserves the opportunity to be healthy. And so many of us got into this work for this very reason. The other quote that I'll share is from Dr. Kamara Jones. I'm sorry, there we go. She writes, are health disparities morally problematic? And is there a moral obligation to address such disparities? And she goes on to answer that question, as you might expect if you know Dr. Jones. Yes, we have, as a society, a moral obligation to create health equity. Now, how we do that, we may not agree, but morally and simply as advancing our democracy, we need health equity. So what about the economics? Whether we like it or not, healthcare in the United States is big business. It's an industry. I've heard some people call it the medical industrial complex. And, health inequities, differences in the quality of care, access to healthcare services, and structural barriers that impede the overall health of communities across racial and ethnic groups, those are well documented. We know that there are health inequalities or inequities. We also know that, like I said, healthcare is a big business. And many people have been studying and publishing about this question of the economic impacts of health disparities. And this particular study that was put out by the Kellogg Foundation and the consulting firm or research firm Alterum, they said there's a potential economic gain of $135 billion per year if racial disparities in health are eliminated, including $93 billion in excess medical care costs and $42 billion in untapped productivity. Now, I don't know about you, I don't spend a lot of time thinking in terms of billions of dollars. And I don't think a lot about how much the work that I'm doing is going to save the country money or save employers money. But in this webinar, we're going to dig into that just a little bit, bring it down from the billion scale, from the national scale, more to the local scale. But we're going to talk about this economic argument because whether we like it or not, that is on the minds of our healthcare leaders. So first of all, who am I talking about when we say healthcare leaders? Well, government is a huge one. So the primary funders of healthcare in the US, mobile or otherwise, are the federal, state, and local governments. So when I'm talking about leaders, if you're thinking about, I hope you'll be thinking about who are the leaders I want to influence or need to influence to get support for my program, whether it's a mobile program or another kind of program that you run or want to run. Think about who are those federal, state, and local officials that you need to influence. And often it is the kind of folks that NAC is talking about, and the senators and the representatives that Nova mentioned that were instrumental in getting the Mobile Act passed. So sometimes it is those folks, elected officials at the federal level. And often it's also state officials, so state representatives who have the power to pass laws at the state level. And even, and I see this a lot in mobile clinics and community health in general, local governments have the ability to address health disparities through their funding and their policies, not just in health or health care, but in so many areas that touch social determinants of health, like housing, education, transportation. So knowing who those officials are, and as best you can, think about actually who is it? What is their name? Or what is that group of people? So maybe it's the county commissioners, or maybe it's Senator Rosen, or someone else that you think, if I really want to get more funding for this work, who do I need to influence? And I bring government up first because they are the primary funders of healthcare in the US. There's many other stakeholders besides the government. First of all, patients, not just in terms of patients as people who receive care from our healthcare system, but they also have receive an economic benefit when we reduce health disparities. And they bear a significant burden, especially in the communities that some of you described, where uninsured rates are very high, Medicaid is not an option, and folks are paying out of pocket or not receiving care and then coming in later with much more serious and expensive health issues. So patients, hospitals, whether a hospital is for-profit or nonprofit, many of them have enormous budgets. And whether they're for-profit or nonprofit, they operate like a business. They're looking every month at their balance sheet, at their revenues, expenses, their assets, their liabilities. That hospital CEO or CFO, they care about people. They got into this work because they want to take care of the health of the community that that hospital serves. And their job and the success of their hospital depends on the bottom line. And so they are also looking at healthcare from an economic perspective. Community health centers, payers, employers, all of these organizations have budgets, and they're looking at both the expense line and the revenue line to see how do inequities help us or hurt us. So let me just take this last example because I don't think we think about it often enough. Employers. So employers, drive the economic engines of our communities. And interestingly, in most communities, the largest employer is healthcare. So there's an interesting relationship there. But any employer, healthcare or otherwise, their economic well-being is threatened, and some of you mentioned this in the chat, by issues like absenteeism, turnover, burnout. Of course, we've all seen that, especially during the pandemic. And then also employers who don't have a healthy workforce see reductions in productivity and increases in healthcare costs. And that is then reflected in insurance premiums or in the amount of money they have to pay their workers so their workers can afford healthcare. So that economic benefit of ending disparities holds true for all different stakeholders, including employers. So to round that out, health equity is a moral and economic imperative. And every company, whether they identify as a healthcare company or not, is a healthcare company. Everyone has a stake in health equity in our country. And there's a great paper published by the World Economic Forum that goes into this in more depth. So I want to transition now into talking specifically about mobile healthcare and what mobile healthcare brings to the table and how we can position mobile healthcare in our efforts to start or expand our mobile health programs within that larger universe of business-related incentives. Because in the past, I'm assuming this worked because there are many organizations that were founded this way, including many mobile clinics. In the past, you could pitch an idea, especially within a healthcare system, that a new program was good for patients, good for the community, and really not pay a whole lot of attention to the costs and potential for revenue. And that rarely works these days. Many people want to start programs because it's the right thing to do. I mean, we all know that the kind of care we're providing in the community is the right thing to do. But again, those whose jobs depend and organizations' budgets depend on balancing revenue and expenses want to see more. They want to see more. So first, let me just touch on some of the health benefits, because that is important to those leaders and to the communities, and especially to the patients. And I just want to make sure you guys know that the benefits of mobile healthcare are very well documented. And just for example, there have been a number of studies about asthma, about COVID, hypertension, children's oral health, and other topics as well that demonstrate improvements in health outcomes as a result of mobile healthcare. I'm just going to show a few examples. I'm not going to get into the details here, but I'm happy if you want to email me and talk about any of these to have a longer conversation. So this study looked at lower costs for childhood asthma, and it was a mobile program that provided education and medication for children with asthma. And they were ultimately, this bar on the left is the costs associated with care of those enrolled children at baseline. And then after 1 year of receiving those mobile services, how the healthcare costs decreased. And each little section of that bar it is explaining where those costs came from. So we've got ED visits, hospital days, inhalers, and other number of treatments below that, as well as program operational costs for that clinic. And in case you want to look at this study more closely, I should have put it on the slide, but I do have it in my notes. The author is Mary Elizabeth Bollinger, Bollinger. And here's another study. This one is published by Dr. Zuri Song. And again, I should have put that on this slide. Song, S-O-N-G, like music. And he looked at, this is actually conducted in Boston on the family van. And he looked at hypertension over time among patients who came to the family van once, and those who returned one or more additional times. And he was able to see declines in blood pressure, both systolic and diastolic blood pressures over time, and then modeled those results against what we know about the risk for heart attack and stroke. So this first section up here is about heart attacks, MIs, and it shows that MI cost per case is $85,000. And then for this set of data he was looking at, the model shows that we avoided $185,000 in costs related to heart attacks. It also shows reductions in cost related to stroke. And the biggest reduction in cost comes from avoidable ED visits. So he also looked at how many of the patients who came to the mobile clinic would have gone to the ED instead, and how much those ED visits would have cost. So this study showed both health improvements as well as cost savings. And then building on that argument of cost savings, in 2009, Dr. Nancy Oriel, again, the founder of Mobile Health Map, I talked about this a little bit at the top, published this paper, Calculating the Return of Investment on Mobile Health Care. And that essentially measured the preventive services delivered on board a mobile clinic, and took the research around how much money was saved or how many lives, quality adjusted life years were saved by providing those preventive services, and then assigned a dollar amount to each QALY. And that's the research I mentioned at the beginning, with a return on investment of 30 to 1. And we now make that calculation available to anyone who registers for Mobile Health Map. It's entirely free. We're actually launching a new website at the end of the month, which will have even some more interesting tools and better tools, but you can access it, that return on investment calculator, or what we now call the impact tool, on our website right now. So I want to transition into this next section, but first let me check the time. Okay, we're doing good. Let me take a sip of my tea. All right, so we know that we know that health inequities are both a moral and economic imperative. We also know that mobile healthcare improves health outcomes. And we know a little bit about how it might improve economic outcomes. But there's more that we needed to know, and I'll get into that here in a minute. One of the reasons we need to dig more into this economic argument is that our healthcare system is a huge business. So this slide here shows projected growth in national health expenditures. And this is percentage increase, but I think if you look at, I don't think it's in this table, but there's another table in this paper that looks at the total amount of health expenditure, and it exceeds $4 trillion. So again, I can't even wrap my mind around trillions of dollars, but it's an enormous industry. And then we also know that US healthcare expenditures continue to rise as a percentage of our gross domestic product. So there is an economic pressure on our country to look at healthcare through a financial lens, through an economic lens. Also, I mentioned the study by Dr. Oriel about the return on investment. And over the years, as we've shared that paper and shared that argument, one of the pushbacks that we got was, okay, well, that's good. You're saving society money by saving those lives. That's great. We want to save lives. Though some people would also push back, and they might not do this publicly, but say, actually, if you save those lives, those people are going to live longer and they're going to cost us more because they're going to be getting healthcare for more years. But we won't get into that. But there was some doubt about whether or to whom these lives saved mattered. Who was really benefiting from these lives saved. It's strange to even say that because, of course, we want to save lives. The other piece of pushback that we got, and this really varies from community to community, but some folks said, okay, we see that you help to avoid unnecessary ED visits. And that's great for the patient. Nobody should be getting regular care, especially care doesn't need to be delivered in the ED. Nobody should be getting that in the emergency room. But we say hospital X, we get paid for those visits. Those patients have insurance or they're covered by a government program. And if they stop coming, how are we going to pay the staff in our emergency room? Are we going to lose revenue because you're preventing people from needing our emergency room? And that, like I said, that argument varies everywhere. So in a state like Massachusetts, where I am, and more than 95% of people have insurance, we expanded Medicaid very generously here. And that argument actually holds up, because hospitals generate revenue by people coming to the ED because they get reimbursed for those visits. In other states, for example, where Medicaid hasn't expanded and there's huge amounts of uncompensated care, those hospitals may, not always, depending on their other revenue streams and how they cover that uncompensated care, but they may be able to see that argument of, we don't want folks coming to us for this care. It's too expensive. We'd rather them get the care in a less expensive setting like a mobile clinic. So what we did in response to this pushback, or to these counter arguments to the return on investment, is we interviewed 25 healthcare leaders across the United States and asked them how their business objectives aligned or didn't align with the work of mobile clinics. And we analyzed those interviews and looked for themes across them. And 6 themes came out. And I'm not going to talk about all of these in detail. You can read the report at mobilehealthmap.org and download it. If you go to mobilehealthmap.org/business case. So I'll let you look at it in its full depth when you're ready. But let me just highlight a few of these themes. So the 6 themes were mobile healthcare can support an organization's culture. It can help with various aspects of business strategy. It can have a positive, not always, but a positive budget impact, meaning increasing revenue or decreasing costs. And it can advance health equity. Also, we have these 2 themes at the bottom that really speak to the foundation of mobile healthcare. So one is community engagement. We can address, we can build a mobile clinic and park it in a neighborhood, but if we haven't engaged the community, nobody's going to come. It's not going to be sustainable. And then data. Everybody wants data these days. Sometimes that data can come in the form of stories and anecdotes, but more and more people want to see the numbers. How much did you save? How many cases of undetected diabetes did you diagnose, and what happened to those folks? So we need more data. We heard that from almost every healthcare leader that we interviewed. We also heard this: when mobile clinic leaders show through data that the mobile clinic benefits the organization, decision makers will be more likely to support continued efforts. Now, I hope that you're not feeling disheartened listening to this and thinking, the organization, they should support this work because it's the right thing to do. And yes, you're right, they should. And they're concerned about their bottom line. Some people talk about this, and I used to hate when I heard this phrase, but I'm sure many of you have heard it as well. No mission, no margin. Got that wrong. No margin, no mission. If we don't have a positive margin, financial margin, meaning if we're not getting enough money in the door, we have no mission. We can't deliver on our mission. I say I cringe every time I hear that because I think it's an oversimplification, but there is some truth to it. And so as we advocate to start new programs or grow our programs, we need to put ourselves in the shoes of those mobile clinic leaders. And this business case helps us to do that. One piece that really resonates with leaders, again, those C-suite folks, are these opportunities for revenue and cost savings. Now, let me just say, nobody or hardly anybody starts a mobile clinic to get rich. There's a few for-profit mobile clinic companies out there, and I don't think they're getting rich either, but none of us are in this business to generate a ton of profit, but we would like to break even if at all possible. So, and some mobile clinics do actually generate revenue for their organizations. And so when we talk to healthcare leaders about mobile clinics, they talked about these 3 things: flexibility and movability. The fact that you can adapt to the changing needs and really meet people literally where they are is a cost savings potentially to that organization, because it's expensive to put in a fixed site, a bricks and mortar site. The community changes, and some of our communities are changing very rapidly, and the people you need to reach have moved to the other side of town or even out into further reaching areas, and your bricks and mortar clinic is empty. So mobile clinics give you that flexibility to go to the community where you're needed and as those needs change. startup costs. So if somebody needs to get started quickly and relatively cheaply, mobile clinics are one way to do that. We just purchased a new mobile clinic for $250,000. Now that's a lot of money, and they can be much more expensive, up to $1 million or more. But before I came to Mobile Health Map, I built bricks and mortar fixed site health centers, and we are sort of minimum cost for a new health center, bricks and mortar, with 2 to 3 exam rooms, a consultation station, a waiting room, sort of the basics, the bare bones, was at least $750,000 in a built out retail space, $1.5 million for a brand new building that we owned. So that's much more than $250,000. And on average, it took us about a year to build each of those buildings, sometimes more. And with a mobile clinic, there can be backlogs in the supply chain. And I know many of us have experienced that in the last couple of years, but usually it is faster to get a mobile clinic up and running and cheaper than building a brand new fixed site. And then also on the revenue cost side is employee engagement. We heard from our healthcare leaders that their employees love being associated with the mobile clinic. Even if they don't work on the mobile clinic, when they see that mobile clinic drive by, they're so proud to say, you know, that's where I work. That's my organization. And they feel proud, and it's a way that they can see the mission at work. So we all got into this work because we wanted to help people, but sometimes, especially for healthcare employees in large organizations, you don't actually get to do the thing that brought you into this work in the first place. And being able to either do it by getting involved with your mobile clinic, or just seeing that mobile clinic out in the world can reinvigorate their excitement about the work and create greater engagement. A little bit more about adaptability. We heard from one healthcare leader, they said, you have much more flexibility. You can get up and move. You can be in many locations during a week and bring in patients and close care gaps and address social determinants of health by moving around. Patient engagement, also something many organizations care about. And this interviewee said they, meaning mobile clinics, understand the community because they are within our community. They understand our culture. They understand exactly what it is that we're going through. Sometimes when I try to say things and they don't come out right, they already know what I'm trying to say. And I apologize. This is a quote from a patient, not from a healthcare leader, as you can see. So I'm going to round us out these last 5 minutes with a few recommendations. How can you take this business case and apply it to your organization? How can you create your own business case? So first of all is to understand your organization's strategic priorities. Put yourself in the shoes of the board of directors, the CEO, the CFO, whoever is the ultimate decision maker in terms of how your organization uses resources. Also, consider other stakeholders' business cases. So what I mean by that is, you know, you need to get your organization support. That's one goal, but also there may be other organizations in your community or in your state that you need to influence. So going back to the beginning, when I showed that slide about federal, state, local, maybe it's your county commissioners who are going to put the money into this mobile clinic. So you get your organization support. They say, yeah, we're ready to go. Just find the money. And you know your county commissioners want to do something about health disparities. So what are the county commissioners' pain points? Now, one, maybe they want to get reelected. So they want to do something good for the community that they can brag about when it's time to get reelected. It could also be that they're trying to balance the county budget, and maybe the county's paying a lot to the hospital for uncompensated care, and they would like to see that care go more into prevention. So there's the other stakeholders as well. You have to think about what their pain points are and speak to those when you make your argument. Next, and somebody mentioned this, sustainability is an important issue. I encourage anyone who is thinking about starting a mobile clinic, or maybe you're just getting one started, sit down with your leadership and create a 5-year financial forecast, essentially that plan for sustainability. So maybe you got a grant to fund the new site, but the new mobile clinic. How are you going to fund that? And what revenue are you going to generate over the next few years, next 5 years, really? And what are going to be the associated costs? Now, will the future look exactly like that 5-year plan? No, probably nowhere close to that. But just the exercise of sitting around a table and saying, okay, well, if we get reimbursed for these services, that's one line of revenue, and that'll allow us to provide these services which cost X, Y, and Z, but we're still going to need some more revenue, especially over time as our volume grows, but our reimbursement isn't going to grow, or we're going to see more and more uninsured patients. It's a great exercise to plan for the future and to gain buy-in for sustaining your program, because those leaders were part of developing that plan for sustainability. Also find allies and champions. And I know everybody talks about allies, champions, partnerships, collaborators. What I mean is, like, find some friends in your organization or these other organizations that you want to influence, people who will be your champion, who will get excited about mobile clinics. And a lot of people get excited about mobile clinics. So finding those folks who will stand next to you, stand with you, speak, maybe have connections to other people in the organization. For example, many of the leaders we spoke to talked about their marketing department and how the marketing department loved their mobile clinic. It was on the front of all their annual reports, all of their marketing materials. It was in their local video or commercial. So find those people who are excited about your clinic, because while it might not come out of the marketing budget, that chief marketing officer or whoever is strategizing around your organization's reputation and brand, they can get behind you and support you in that effort to get support. And then finally, prioritize evaluation and learning. And I don't have time to say more about that, which is too bad, because that's my sweet spot. But call me, email me if you want to talk more. Finally, the future of mobile. I can't even get into this, but again, if you want to talk more about autonomous vehicles, or mobile squared, which is mobile and telemedicine together, feel free to reach out to me. I want to thank my collaborators, the researchers, the funders, including the Lowenstein Foundation, all of the advisors who helped with the business case. And then finally, check out our website and send me an email if you want to talk more about anything I've discussed today.
Thank you so much. That is extremely helpful. I learned a lot just sitting and so many aspects of that I've never thought about. The part about the emergency departments and how emergency departments may be hesitant to lose patients. I have never thought about that. I'm in Tennessee. We're a non-expansion state, and we're always looking for ways to get people out of the emergency department. And so lots of that was fascinating, but some of that I've just been sitting here thinking about, like, wow, I've never even considered that. Thank you so much to all of our guests today. So much helpful information. Thank you so much to those of you that contributed to the chat. And so for sharing with us what you're doing and even just who you are, we really appreciate it. Again, the recording for this session and the other sessions in this series will go out this week. I'm hoping to send that out tomorrow. And that will include a link to our Lunch and Learn series, where we're featuring a different unit every week. And that begins a week from today at the same time. Another thank you to the Lowenstein Foundation for funding this. We really appreciate the opportunity to focus on mobile healthcare this way. Thank you so much, everyone. Feel free to reach out to Molly or Nova or myself if you have questions, if you want to talk more. You'll be able to get all that information on the website too. Thank you so much, everyone. Have a good afternoon.